Welcome to Senadhipan Education Foundation. Today, this is a historical event which is going to happen. We have a world-renowned faculty here. Before introducing the faculties, let me go through the short history of Senadhipan Education Foundation. It was launched in 2012 by none other than another world figure colorectal surgeon, Professor Sion Han Kim, by releasing a set of educational DVDs at Trivandrum. After that, he visited our hospital till 2020 July. We were doing only fellowship courses and contract classes. With the onset of COVID, we started online programs. And the logo was released by none other than Dr. Palanivelu himself.
Thank you, Nisha, and thank you, Baiju, for inviting me to be today's more remarkable event, part of this. And Goose, good friend of mine, and since he started laparoscopy, we're very happy about it. Dear friends, Parvinder Lal, Professor Parvinder Lal, Vice President of National Board Examination, and John Abraham, ASI, ex-past President, and friend Raman Koil, President of IAGS, and Baiju. I think it's happiness to be here to launch the logo of Senadhipan Education Foundation.
After that, we conducted a lot of online programs. We streamed live surgeries from the platform. We had live lectures from eminent faculties. And we have certificate courses through this educational foundation. Now, I've done almost 20 webinars. We have got global acceptance. We can see the meeting participants here. On other meetings, we can see that 889 participants were there. And majority was from India, and the participants from across the globe participated. Now it's our honor and privilege to welcome Professor Joel Leroy and other panelists, Dr. Bala and Dr. Rajesh TK. Actually, Professor Joel is a jovial person. We met at different places. This is a picture taken when he came to Coimbatore for a conference. He did a TME there. And also I met him when he was the course coordinator for IRCAD Taiwan. I was one of the faculties there. He is actually the founder and chairman of Hanoi High-Tech Digestive Center at St. Paul Hospital, Hanoi, Vietnam. He's a leader and pioneer in advanced colorectal surgery since early 1990s. You will not believe, early 1990s. He is a surgical expert, researcher, inventor, and an international educator. He took his MD from University of Lille in France 1976. In the same university, he became professor of digestive surgery in 1997. He is a visiting professor to many universities, University of Winnipeg in Canada, Osaka Medical College, Japan, Rectal Taiwan, Jiangong Hospital, China. He is a visiting professor to Shanghai University also. He is honorary fellow to Royal College of Surgeons, England. He got Pioneer Award in Minimal Invasive Surgery by SAGES in 2013. Now at the St. Paul Hospital, he is started colorectal screening programs in which he screens almost 7,000 people every day. You cannot imagine that in our country. 7,000 people are screened every day by his program. So we are really honored to have you in this platform. We are going to have a feast on colorectal surgery, that too TME. Thank you, sir, for joining us. This is not a Hollywood star. This is our Rajesh T. Kochupadi. He is a consultant colorectal surgeon working in, he works in 2 continents, one in United Kingdom and the other in India. He works in Plymouth, United Kingdom. He is the academic director and robotic surgeon in GEM Hospital, Chennai. He is that's why he is in this forum for this webinar as a panelist, because he is the first Indian surgeon to do a TME. He is a tutor to Royal College. He is not as serious as he is looking in this photo. He is actually belongs to the first batch to pass out FRCS from India. That is in 1998. He has got a British Award for Best Paper for British Hernia Society 2009. He is well trained. He is one of the few people who got trained in the initial period itself in TME. He is a visiting consultant in Care Hospital and Newfield Hospital, UK. Welcome, Dr. Rajesh. Dr. Bala requires no introduction to this audience. He is the HOD of GA Surgery Clinicals Global Hospital, Chennai. You all know he is a positive thinker, academician, and he brought, that is the plus point of Dr. Bala. He has brought many eminent figures to India, like Professor Leroy, Professor Gagner, Professor Kusheri, Professor Bryce Guy, Dr. Armando Melani to India to perform surgeries, and that's why we could progress in India as advanced colorectal surgeons. Welcome, Dr. Bala, to this audience. A few advices or instructions to the Zoom participants. All are requested to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene in between the talk. Everybody will be given permission to unmute their mic and give their opinion. If you are in a portable device, please mute your audio and video while moving. And when Dr. Leroy is presenting, it is preferable to hide your video so that you can get a high definition of the videos. Now, before giving the mic to Professor Leroy, let us invite you to the next program by none other than our hero, Dr. X. Tme is from Kerala, who is going to speak on surgical strategy for pancreatic cancer. And Dr. Piyush Shani, Head of the Department of GI Surgery, All India Institute of Medical Science, Delhi, will be moderating the session. Thank you all. Please enjoy. Over to Dr. Leroy. $253.
Hello? Do you hear me?
Yeah, please go ahead, sir.
You have sound?
Yeah, sound is
Okay.
audible.
Thanks.
Now in this Zoom platform, 258 people are already entered and some are in the link only, 260 now. And we are expecting almost 900 at least, both the link and the Zoom platform.
Yeah. Okay. So 9 in India, I suppose.
Thank you.
9 p.m. So, Professor Baiju, many thanks for inviting me, participating to this webinar on transanal rectal resection for cancer, and particularly transanal TME. Thanks to Professor Bala, a good friend I met, and he was the first inviting me a long time ago. After Barry Stalky, he's a good friend too. And every time I was coming in India, first I was coming in Coimbatore. Now I have understood I have to go in another place in Chennai. And I don't know if I can begin my lecture now. I have to see where it is.
Share screen.
Okay, it is there. So I will begin the lectures. Is it right?
Yeah, please.
Okay. So I'm choosing where I have to go. Partager. It's good. Have you the picture now?
We can see.
You can see.
Yeah.
Okay. So as you see, I'm Professor Leroy, now working in Hanoi. Unfortunately, I cannot go actually due to the COVID pandemic. Okay. We cannot activate. Okay. Oh, thanks to all of you. Thanks for to all the participants to share their time with us. And I will speak of transanal TME for rectal cancer. And to explain, we are coming from open to go to no scar surgery for TME. And we will see how and why we have to perform a pure transanal TME, only to show the abdominal scar from open to now in 200 years, we will go from left to right and less scar. During the last decade, we have seen a great number of transanal procedures, and these for treating cancer, mainly early cancer, where we can do limited oncologic resection. But currently, the most popular surgery is rectal total mesorectal excision, the TME, done by open or more and more by laparoscopy. Transanal TME has been proposed as a method to improve surgery of mid and lower rectal region. The Transanal TME allows an endoscopic approach to perform a TME using standard laparoscopic instrument with excellent visualization provided by regular laparoscopic video platform. Pure Transanal TME, it is why you wish I speak, is a minimally invasive transanal approach with dissection and ultra-low colorectal anastomosis through the transanal route. It is an innovative and promising technique to treat selective rectal cancer without diverting stoma, but it is too challenging. Rectal TME, you know, are often challenging procedures, especially in patients with deep and narrow pelvis, bulky lesion, male gender, obesity, and after neoadjuvant chemoradiation. TME is probably a new innovative approach for treating this patient. The purpose of my lectures are to discuss the specifics of the technique, advantage and disadvantage of TME, the indications, the real need, and the training program will be discussed too. First, we have to speak of TME, what it is. First, this is a procedure to remove the rectum in case of cancer, doing an oncologic vascular approach with lymphadenectomy. Removing the rectum and the meso totally, this is a total mesorectal dissection. This is a part of the TME. Distal division of the rectum, that can be of the distal rectum or coloanal rectal junction. And doing the anastomosis on the lower rectum or anal anastomosis. We can include mobilization of the left colon and splenic flexure, particularly in obese patients, depending on the anatomy, but this is not a part of the definition for me, particularly in slim patients in Asia, where a long sigmoid loop will help the surgeon not doing a complete mobilization. And sometimes, and more, it is recommended to do lateral lymphadenectomy for advanced tumor. Oncologic vascular approach. This is approached by laparoscopy. As you see, it is well known. I think due to laparoscopy, we have had a very long diffusion, very fast diffusion of the technique worldwide, with so many surgeons doing perfectly or more and more perfectly the procedure for doing TME. And as you see, we can do fine dissection at the origin of the HME, doing a distal division after skeletonization of the origin of the HME, distal division after the left colic artery. We do the same for the vein. For that, we have opened the peritoneum and we have dissected in the retroperitoneal space, the HME, IMV. It is retroperitoneal dissection. We have to complete the dissection lower around the rectum, respecting embryological plane of the fascia and doing the dissection posteriorly in the holy plane between the presacral fascia and the propria fascia of the rectum. Laterally, we will have to do a dissection medial to the side walled fascia that is protecting, protected the plexus. And as you see, I am dissecting the different branches, neurovegetative branches going to the rectum, coming from the lateral plexus. This is on left. So if we do a perfect dissection like this, we will respect lateral plexus with the anterior branch of this plexus going to the urogenital tract. We will do the same on the left. Then we have to dissect anteriorly. Dissecting behind the vagina, it's easier than in male patient. We have to dissect behind the Denonvilliers fascia, or we have to dissect anterior to it in case of advanced tumor, big tumor. This is the Denonvilliers fascia we are dissecting. Or, as I will show to you, we will have to dissect between the two layers of the Denonvilliers fascia. Then, at the end, we have to divide the rectum distally, or to compare with TME, doing, in this case, intersphincteric dissection. We dissect very low, and we finish the procedure by transanal approach, doing intersphincteric rectal resection. And this is a technique called up to down dissection before doing anastomosis on maid. In this case, because it's a coloanal dissection, as you see, we will do the suture by transanal approach. So same than TME, we have no more abdominal scar, no abdominal extraction of the specimen, only abdominal trocar. Only to remember, because it is important, when we do up to down, down to up procedures. What is the Denonvilliers fascia? Denonvilliers fascia is a primitive peritoneum with a fusion between the two layers, and it is what we can find. So it's a Douglas pouch prolongation that is fused. And as you will see in this case, we will dissect between the two layers. So some people are saying dissect posterior, dissect anterior, I can say dissect between. And this is what I'm doing at this moment, doing a dissection between the two layers of the Denonvilliers fascia. But it's not always so easy, particularly after radiochemotherapy, when there was advanced tumor, T3, T4, tumor, anterior particularly. As you see, at 6 weeks after, we have a lot of edema. It is more difficult. Energy is diffused in the edema, and even if we have skill, as you see, this is a big edema. We have to take care for the plexus running around, and majority of case we will dissect anterior to the Denonvilliers fascia. The best is to have good equipment when we do this dissection. You see, this is a good retraction, female patient, large pelvis, easy to dissect, and we can do very distal dissection. And it is why some people propose to do with robotic similar. Only to tell you, today, gold standard, even for Bill Hill, is laparoscopic TME worldwide, due to the training we did, due to the lot of live demonstration, a lot of meeting worldwide, and it is a fantastic diffusion, better than book. Concerning transanal, Common technique used today is laparoscopic assisted transanal TME. This is what people are calling TME, TME, transanal TME. As I said, TME, it's a sum of steps, and it's not only the mesorectal dissection. So laparoscopic assisted TME, it's a hybrid TME procedure done by minimally invasive surgery using laparoscopy or robotic abdominal approach, doing dissection and up to down, and doing ultra-low colorectal or coroanal anastomosis through the transanal port to improve distal dissection of the rectum and avoid a lot of multi-fire cartridge or to cross cartridge when we are dividing the rectum. It has the potential to be safer for the distal resection margin by improving access and precision of dissection and stapler placement. Pure TME is a pure notes rectal TME technique. I did for the first time 10 years ago in 2010, June. Is a minimally invasive transanal approach without laparoscopic assistance. All the dissection, mobilization, vascular approach, ultra-low colorectal and coroanal anastomosis are done through the transanal route without diverting stoma. For when we do TME procedures, concerning the patient preparation and the position to perform and the team position, first, we do a perfect bowel preparation, as we do for all the patients now. And the entire colorectal tract is cleaned preoperatively using washout and antibiotherapy. The patient is placed in a supine position with the arms alongside the body and the legs apart. The team is positioned if we have pure transanal only between the legs. If we have to do laparoscopic assisted procedure, we will have two teams, one for the abdominal approach, one for the transanal approach. The ankle and leg will be secure to the operative table. For doing procedure and transanal dissection, we have to use platform, sophisticated platform, and there is different platform. I will say some are flexible. You have seal sport, you have a flexible transanal gel point, and you have rigid transanal platform, particularly the TEO by Stotz. This is my choice, and you will understand why. This is a big trocar, 4 cm diameter, connected to insufflator, and now it is recommended to have exsufflation. And as you see on the handle of the system, you have tape to exsufflate, control exsufflation. One other is to clean, doing insufflation on the top of the platform. You have different lengths, 7.5 centimeters, 15 centimeters, and 20 centimeters with different type of scope. You can use rigid cup with the advantage having the possibility to put the scope and fix, so you can do solo surgery, no assistant manipulating the camera. So that means more fixity, and having also the possibility to have flexible cup and using classical laparoscopic instrument or curve instrument with different shape. There is a problem actually. And you know, I've seen that in your country today you had, or yesterday you had around 80,000 COVID cases. It's terrible. And for Wexner, it is recommended more and more to have a personal protective equipment for the team, for the danger to be contaminated, to do testing of the patient before operating them, to use a negative pressure environment in the OR, but also in limited in the operative field. And this is one of the advantages, I will say, of the TO, because with the TO, the insufflation is to clean the space. It's not to have a high pressure to see better. The 4 centimeter diameter of the TO is a circular retractor, as you will see later. So method of access, particularly for laparoscopy, when we have insufflation, doing pneumoperitoneum is considered as risky. And we have to know if the patient are not contaminated before operating. As you know, you can have virus in the pneumoperitoneum, you can have virus in the digestive tract, and particularly in the colon. For Lassie say, yes, perhaps, we don't know, but if you are trained, if you have a good skill, good experience, perhaps you can do. This is also a work of my friend and pupils, Ronan Cahill, that is concluding recently, even if we don't know, there is a risk during a pandemic. And even if you use a specific trocar, more and more popular, for example, air-sealed system, and it demonstrates on animal model that there is high risk of contamination of the abdominal cavity of the team, and including when we do transanal TME. So for Italian team, in geographic area with high prevalence of COVID-19 in the population, they recommend to do tests. And in case of positivity of the test, we have to consider the relative risk versus benefit as in the management. So if we operate the patient, if we have good equipment, good team, we have first to close distal the rectum. Why? Risk of contamination by cancer cells, risk of contamination by bacterial contamination and virus now. And it is necessary to do adequate purse string closure, occlusion of the rectum, using a full thickness sutures with a monofilament that is better, is sliding better, 2 0 sutures or more. This is the beginning of the procedure. When you do the suture, don't include too deep. So it's easy when the lesion, the tumor, is at distance of the anal canal. But in very low rectal lesion, when we try to place the platform, the shape of the device, particularly it's a flexible device, may overlap with the dissection area. In this case, an open approach using Lone Star retractor prior to inserting the platform is recommended. In this case, initial rectal translation and dissection, and the pursuing are performed in a non-endoscopic open fashion, depending the localization of the tumor. To remember, Reilly classification of distal rectal cancer. You have a type 1A, B, 2, 3, and 4. You see more and more depending the position from the anorectal junction. So above 2 centimeters, between 1-2 centimeters, less than 1 centimeter. And in type 4, it is invasion. This is indication of APR. In type 1A, for tumor located above 2 centimeters of the anorectal junction, we can generally, particularly if it is a rigid platform as TO, place the platform and do the pursuing through the platform. After we have positioned the platform, we will introduce the platform, after soft dilatation of the sphincter, local disinfection too with povidone iodine solution, and I remember the patient had the bowel preparation before, and lubricating the anal canal and operative platform. For ultra-low rectal tumor, less than 2 centimeters, we will have to do the purse string, as I said, after we have free the distal rectum under the tumor. As in this case, you see, we will do intersphincteric dissection for the tumor you have seen that was visible. And we do intersphincteric dissection after we have cleaned and the bowel before operating the patient and during the procedure with betadine, with povidone iodine solution. And as you see, we do intersphincteric dissection, taking care. Why intersphincteric? Because it was a tumor fixed at the upper part of the anal canal, and we will continue the dissection before closing. It is very important to close. Only to remember, in 2000, Professor Watanabe from Japan said he was doing transanal approach for a lot of patients, and they stopped because they had high rate of local recurrence, because they don't know at this moment that there was a risk of spillage of cancer cells with fixation. So the distal fraying for placing the platform will depend of the type of position of the tumor. For type 1B, we will do a sleeve mucosectomy. For type 2, we'll do a partial intersphincteric resection. For type 3, we will do a total intersphincteric resection. And as I said, type 4, it's not for TME, it is APR. Concerning laparoscopic assisted TME, the common technique used actually is a conventional laparoscopic or abdominal laparoscopic approach with single multiport with 1 or 2 teams. During the laparoscopic step, surgeons will evaluate the possibility to dissect and to see particularly if there is a lot of adhesion in the pelvis, evaluate the possibility to mobilize the colon and to dissect the vessels. Vascular dissection will be done with lymphadenectomy, left colonic and splenic fascial mobilization will be done. lower, there is no consensus where to stop the abdominal step. You have seen when we do intersphincteric resection, we do maximum by laparoscopy. And an option from DAPRI is to stop at 1 centimeter down the promontory, where the upper mesorectum is inside and dissected from the presacral fascia in avascular plane. When we will see later the beginning, when we have dissect, and in 80% of cases, surgeons are doing only distal dissection of the low rectum. As you see in this case, we do mixed. We have done maximum by Transanal and do a problem of equipment, and because the patient had a radiochemotherapy before, we finish the dissection at this level and we continue by laparoscopy using a single port in the right iliac fossa. And it is what we have done since a long time as other authors. And as you see, we have the root of the mesosigmoid beginning to be dissected. All the dissection were done by laparoscopy. And we come back and we see the position of the TO and the emphysema in the meso due to the dissection. And we will continue the dissection by laparoscopy using a single port, and we can use the Transanal approach for doing the division to complete, so as a trocar for doing the dissection. This is a case of diverting stoma necessary, in this case, after radiochemotherapy, in right iliac fossa on the site of the single port. Pure TME, pure notes, rectal TME. First, good selection of patient. As you see, it's a small lesion, mid-rectum, and not too advanced tumor. The first step, I remember, is to close distal the rectum. So in this case, we can introduce, after soft dilatation of the anus, we can do a purse string. We do 1 centimeter distal to the tumor we see. Only to remember you, in the beginning of 80s, it is Gerald Marks, the father of John Marks, that did a procedure like this, not with a TEO, for tumor to preserve better the sphincter, because we can see the distal limit of the tumor. We call that data. Next is to do posterior incision of the rectum, 1-2 centimeters if we have, under the purse string, posteriorly first, and we dissect from down to up. It's not a difficult step. Then we do lateral dissection. Watch when we open like this. This is a fixity due to the TO. The scope is not moving. We see there the mid-rectal artery on the left side of the patient, and we will continue the dissection sliding medial to the sidewall fascia. You see the sidewall fascia is the white structures, and we will continue the dissection from down to up, completing a little anteriorly and to stay medial to that, as we have seen when we were doing up to down. We will do the same on right side of the patient to see the rectal branches, as I tried to show you at the beginning. Then we continue anteriorly. We reach and we go slowly to respect, particularly in male patient, the urethra. We have to dissect the anterior plane slowly to reach and to be behind the prostate. You see the dissection of the root of the mesosigmoid upper part, and this is plexus, left plexus, and with left trunk, left branch of the superior hypogastric plexus. This is the root of the mesosigmoid at the level of the promontory. We are pushing the rectum inside the abdominal cavity to have a better retraction. We dissect laterally the attachment of the mesosigmoid, and we have to continue higher and higher. You see the ovarium is in the field. This is a IME visible. Watch, we will push the TO, and the TO retract the ovarium, and we see better. And slowly, we continue the dissection, reaching, this is the left colic artery visible, as you see. We have the IME here, we do aorta, IME, and we will do in this case, it was a T1 SM2, the distally, to the left colic artery, you will see there, the superior rectal artery, and the vein, you see there, and you see the division using a sealing and removing en bloc the meso. In this case, we had 20 nodes in the meso, like this. So this is next step. After we are free, we will do the specimen extraction. Ooh. We have to control the, oh, sorry. I don't know what I have. I have a problem with the.
You can go to the previous slide.
Okay. Okay, I do specimen extraction. This is classical, the specimen examination, very important. You see the purse string that close completely the lumen of the rectum. We verified the quality of the mesorectal excision. So that seemed very good in this case. And finally, we do the anastomosis, end-to-hand anastomosis. And for that, we introduce anvil of circular stapler, the best, and we connect it to plastic tube. As you see, we have pulled this inside the TO, and we do the purse string with a TO. And before tightening the purse string, we pull the anvil. that is introduced in the proximal column, we keep safely. As I said, the best is probably to use hemorrhoid stapler, and we do end-to-end anastomosis. So this is control, and we do endoscopic control too. Other possibility is to do side-to-hand anastomosis, mechanical anastomosis, as you see here. This is mobilization done by Transanal. We push the anvil, we are fixed with suture to have a landmark, and we will do the anastomosis. We can do, as you see, same closure, and we close around the shaft. It is what I said to you before. It's easier with a long shaft, that is the shaft of the hemorrhoid stapler. So it's a big anastomosis. And we connect. We do like this, anastomosis. And we control, as you see, the quality of the anastomosis. We can do also handmade anastomosis. It's a side-to-hand manual in this case. And this is similar, but only with manual sutures. As I said, oh, sorry, it is a patient. Okay, so what are the tricks? Tricks is to do posterior retroperitoneal dissection. Why? Because all the vascular structure are posterior, and it is demonstrated in the literature that for doing a pure transanal approach, the best approach is to do a retroperitoneal approach. And it is what I published in 2012. Transanal, what are the results? As you see in the literature, what we see. Transanal versus abdominal lower rectal dissection. For Rullier, there is no real difference. To demonstrate further advantage, it's necessary to do more study. Comparing robotic versus transanal, and for 1A, rectal robotic TME is feasible as a laparoscopic TME in terms of technique, and in their practice, in case of difficult case, robotic TME allows complete rectal dissection by abdominal approach, while laparoscopic TME requires a transanal approach. So this is what we know since a long time. This is a RIS, the intersphincteric resection. Transanal versus TME versus laparoscopic TME, no difference for John Marks concerning oncologic results, up to down or bottom to up. They concluding that transanal TME is promising progressive approach to notes and deserve additional evaluation. So what we can say, results suggest equivalent oncologic results, anastomotic leak and positive resection margin rates. not consistent with this, we have a lot of paper showing early series report, anastomotic leak rate very high, and a lot of complication concerning injury of ureter and solid organ. Concerns also exist the problem of circumferential resection margin that seem better for some people, but worse for other people. What we think, there is not yet randomized evidence for the benefit of Transanal TME. A prolonged learning curve for Transanal has been described with worse outcome seen in as many as the first 50 cases performed. This is a work of Norwegian colorectal cancer group. They wrote 1 year ago that the recurrence rate after Transanal TME is very high. And they conclude that the problem of insufflation through the perineum can provoke some local contamination, and they decide 2 years ago, in 2018, December, to stop to evaluate better, to perform these procedures until a national audit is complete. At present, it seems that the learning curve is a problem. It is a problem for a lot of surgical innovation when experience increase most at the individual or institutional level by training. It's why that Samatala uptake Transanal mesorectal excision, publish initial assessment of structuring training program and the experience of delegate surgeon. And he did work training 81 colorectal surgeons during 1 year, 8 step of 2 days, doing cadaveric dissection, and they have some difficulty. 38 of the participants after respond online survey when they began their experience, and it seemed dramatic because, as you see, the most significant procedure-specific completion reported respondent was urethral injury in 25% of cases after 1 year training, who had performed 1 or more TME operation reported this complication after course completion, and which occur at the surgeon delegates. So, although 2-day cadaver-based training is believing to be superior to other models, they have a lot of full immersion-based simulation in development to train surgeons for this complex procedure. This structure program is interesting, but as you have seen, the risk of injury always exists. It is why American Society of Coronal and Rectal Surgeons should develop consensus statement regarding the training and dissemination of this involving technique, because it is not sufficient. So TME seems to offer similar oncologic results than laparoscopic TME. Pure TME offer more cosmetically pleasant effect, but lacks high-level evidence supporting study. It is a promising, challenging procedure. We can do nose. Nose was described by Palanivilu. See, it is what we do when we do up to down TME with intersphincteric resection. And this can be a good approach and a step to do a full nose procedures. TME, laparoscopic assisted or pure TME, still have many problems. High technical difficulties, high dependency of device platform, limited indication population. We have a lot of contraindication. We have seen the difficulty to dissect mid-rectum for after radiochemotherapy. Therefore, it will take a long time for this technique to be widely applied in clinical practice. Remember, many thanks, and take care of you. Thank you.
Thank you, Professor Leroy, for the brilliant lecture in this platform, Senadhipan Education Foundation. Before going to the panelists, I must acknowledge a few stalwarts who have joined us. Dr. Subramanyeshwar Rao, Dr. H. Ramesh, Dr. P.K. Reddy, Dr. Prakash, Dr. Sudhir, lot of other seniors are joined. Please stay with us for the question and answer session. We are going to the panelists. Dr. Rajesh, what's your take on this?
Yes, Baiju. Thank you for inviting me for this fantastic webinar. Thank you, Professor Leroy, for giving us a wonderful lecture on Transanal TME. And Professor has mentioned the need for a proctor training program in this novel procedure. Without a planned proctor training program, the complications will be high. And as we have seen in the Norwegian colorectal cancer registry, they have shown unexpectedly high rates of early multifocal local pelvic recurrence. So that is very, very important. What he mentioned was a purse string suture. The purse string suture is very, very important in preventing recurrence. What I tend to do is, I do first purse string suture, over which I will put a loop to control again. And once I have dissected out, I do the second suture to close the defect. So by this, no mucus spillage happens. What's happening is the mucus spills into the raw area. With the pneumoperitoneum, it produces multifocal recurrence. So it's very important to identify the cancer biology. Okay, if you spill the cancer cells, it will produce recurrence. So you need to have a proctor training program to prevent this problem. Then again, the next problem which we face is high incidence of urethral injury. Again, the importance is to have a proctor training program. What I tend to do now is using an ICG into the urethra and making sure you are not damaging the urethra. With the ICG camera, I make sure there is no urethral damage. That is the second problem. Next problem which Norwegian registry is facing is carbon dioxide embolism. So the carbon dioxide embolism is a new entity coming up because of the transanal TME. What I have seen in other centers they are doing is high pressure. They're using 20 millimeters of mercury to control the bleeding. I usually keep about 15 millimeters of mercury. Make sure there is no vessels are opened. If there is a venous vessel opens, the carbon dioxide with high pressure goes in and produces carbon dioxide embolism. That is also a very important step to control carbon dioxide embolism. Then the next higher problem is anastomotic leak rate, which they have mentioned. What we have done is, when we do the anastomosis, the rectal stump has to be released from its adjacent muscular part so that we have a good seal anastomosis. And also we can reinforce with the PDS stitches in the four corners, or you can do a hand-sewn anastomosis that helps to prevent the anastomotic leak rates. So as Professor mentioned, we need a proctor training program for this particular fantastic procedure. which has been planned. And this is definitely a good way of doing cancer surgery in a morbidly obese male patient with a large prostate. As I am doing both open, robotic, laparoscopic, and transanal TME, I have a pragmatic approach. Selection of patients is very, very important. Okay. What I tend to do is a hybrid variety, not a full pure TME variety. The problem with the full pure TME is we apply pressure onto the bowel. So the pressure can push the mucus into the raw area and you can get a local recurrence. So we in UK, we tend to do a hybrid TME, and we have gone through a rigorous training process to do this particular procedure. This is what I can add. And if you want, I can show our training program. Over to you, Baiju.
Yeah. Before that, actually, Professor Leroy, do you have anything to say about that regarding the mucus discharge from the upper by the pressure of the air?
I don't understood why, when we do pure transanal, the mucosa is pushed outside. I don't understand what means.
Rajesh, can you elaborate on that?
Okay, so the main problem is mucus discharge, which has got a cancer cells which can come out. The main problem is purse string. If you apply,
no, it's okay. This is completely agree. It is what I recommend too. And even if you do a second purse string, sometimes the purse string is not completely tightened. So what I recommend when we have finished to dissect, is to put a loop with a complete tightening that will be more efficient.
Yes. Agree to it, Professor.
Yeah.
No, I have not understood what you were saying concerning, even if it is more difficult, why you don't develop pure transanal TME in selected cases, as I said, due to the mucosal exteriorization. I don't understood.
Yeah. What happens is in the pure transanal TME, when the platform is going in, your vision is, you are focusing on the abdominal part. You won't see what is happening in the purse string area. So you won't see there. The vision, in the vision, you're only seeing the deep, like a inferior mesenteric artery and into the peritoneum, and you do not know what's happening behind you. The behind you is the purse string. So that can open up, you can spill the mucus. But if you've got a tight purse string, double purse string, and you are convinced that it's not going to spill mucus, then you're happy, go ahead with the pure TME.
Yeah. Dr. Bala.
Yeah. See, whatever I wanted to ask, Dr. Rajesh has finished it off. I just want to make two questions to Prof. Prof, somebody who wants to start a TME, what is your advice to take the case of a mid-rectal tumors or low rectal tumors? That's question number one. The question number two is, we say the advantage of TME is the distal resected margin is totally free of the tumor. That is what we are recommending. Is there any evidence to say that TME scores over laparoscopic TME in terms of distal margin, positivity or negativity? These are the two questions I have.
When we read the literature, people are writing best indications are mid and low rectum. As I've tried to show you, a mid-rectal tumor, the main danger for the nerve, it's not the distal rectum, it is the mid-rectum. Because the nerve, the plexus, are on the mid-rectum. After radiochemotherapy, and particularly anterior tumor, where there is a risk of edema, adhesion to the Denonvilliers fascia, I'm not speaking of invasion, I'm speaking of fibrosis, retraction, so difficulty to find the plane, because we have seen from up to down, it's difficult to find the plane. but in my opinion, it is easier than doing by down to up. Because at the mid-rectum, it is the main problem. So people propose to do a combined approach from Transanal and up to down, same time. So two team working.
Yeah. Yeah. Do you want to add?
What?
No, I was just intervening regarding some lot of questions are there from the floor. If you are finished with your explanation.
It's about distal resected margin.
Concerning the respect of distal margin, I have tried to explain, depending of the localization of the tumor, the best is to begin with the platform. So to begin with the Transanal TME, in my opinion, the best is to have not too advanced tumor, not after radiochemotherapy, not after previous abdominal surgery, pelvic surgery, where there is a risk of adhesion. It's why people are doing laparoscopy first to see if we can. And mid-rectum is the best localization, as I have said, and you have seen the patient selected. It was small tumor, T2, mid-rectum. And we have enough distal margin for doing purse string to close perfectly. Putting a platform. But to put a platform in very low, so the distal rectum, I have tried to explain with the classification of Rullier that in the majority of cases, we will begin with a local retraction, anal retraction with Lone Star. That is the best approach, best tools for doing local approach. And we will choose the distal section, minimum 1 centimeters of the distal margin of the tumor to do the incision. And you can understand if the limit is lower and lower than 1 centimeter or 1 centimeter, it's difficult to do a purse string. And it's why it's a risky, as said Dr. Rajesh, to have a local contamination. And it is probably why there is so many risks in the study of a Norwegian group. And I don't recommend for beginners with, I will say, personal training, having no possibility to have a good training in advanced team, to do mid-rectum, not beginning by distal rectum. Even if people are saying, I prefer to do up to down with intersectoral dissection.
Okay, one last question, Professor. In the initial case, would you like to select a female patient or male patient to avoid a
female patient, it's easier. Yeah. And a slim patient, as said our colleague Rajesh, that it's difficult, and I said too, obese, male, narrow pelvis, after radiochemotherapy, a lot of risk factor for doing down to up, bottom to up procedures.
Yeah, Professor, you are telling about redundant sigmoid for a selection, actually. That means that you wanted to avoid a splenic flexure mobilization.
No, for doing pure transanal, or you see, what people are calling TME, it's because they are beginning by transanal. I think it's not reasonable. It's better to begin by laparoscopy and to finish by transanal, in my opinion. This is what we have done since a long time, doing intersphincteric dissection. In case of difficulty, we do by transanal approach. So beginning by transanal is good, but for what? I think if you can have a good dissection by up to down, you have seen in the reference of lectures, there was a comparison between, and it is Rouanet, laparoscopic TME and robotic TME. Robotic TME allow to do majority of cases when you have finished your learning curve by up to down. By laparoscopy, he said, in case of difficulty, they do transanal TME with laparoscopy. So this is a problem, and pure transanal TME. This is innovative technique. It's not to say all the patients will have transanal. You see, in the future, perhaps we will not operate the patient. So perhaps what we are discussing concerning operation, in early case, perhaps we will do local, and it's not only the solution for patient.
Regarding high ligation, low ligation, which one will you prefer in TME?
No, I think it depends on the anatomy of the patient. And oncologically, for a T1SM2 tumor, never it was described having a positive node at the origin of the TME. But when we say distal ligation, we do same lymphadenectomy. We remove the nodes around the origin of the TME, we keep the trunk of the TME, and we divide only the origin of the superior rectal artery. We don't keep the nodes at the origin of the TME.
Yeah, before going to the question answer session, may I ask Dr. Rajesh to show the video of the proctorship?
Yeah. So I'll share the screen.
Please. You can share the screen now.
Yeah.
University Hospitals Plymouth. We are here to present an experience of the National TME training program.
No, your screen is not coming.
Nationally for this training
Just a minute.
Yeah, please.
Mr. Coleman and Mr. Rajesh were selected for the cadaveric training in Dundee, followed by the preceptorship training program from national faculty. This operation involves two teams. The first one operating.
Let me work on it.
Go back and then share your screen.
What is that?
Can you go back to the initial part of the video and then share the screen?
Yeah. Just a minute.
Hello.
Can you see the video?
Surgeons from University Hospitals Plymouth.
Yeah,
We are present an experience of the National TME training program.
now
We were one of 5 centers selected. Hello, we are surgeons from University Hospitals Plymouth, and we are here to present an experience of the National TME training program. We were one of 5 centers selected nationally for this training program. Mr. Coleman and Mr. Rajesh were selected for the cadaveric training in Dundee, followed by the preceptorship training program from national faculty. This operation involves two teams, the first one operating in the abdominal section. The first step involved taking down the splenic flexure, with the associated steps being shown here. Following appropriate mobilization of the splenic flexure, the pelvic dissection is started. The IMA is taken down using clips and an ultrasonic energy device. After that, the left ureter is appropriately identified. This is then protected using a tonsillar swab. Further lateral dissection is started on this, with the swab protecting the ureter. The splenic flexure is then completely mobilized. This allows for the dissection in the pelvis to be started. In the pelvis, there are a few structures to watch out for, including the pelvic nerves, the iliac vessels are also identified on either side. Anteriorly, care is taken to avoid the seminal vesicles. Following on the right side, the right ureter is also visualized. Pelvic dissection does not continue any further until the transanal surgeon is ready. The transanal part is started after placing the appropriate equipment. In this case, the patient selected had a low rectal tumor that was 8.5 centimeters from the anal verge. A purse string suture is placed in the rectum. It is important to make sure the purse string is complete. This allows for a good seal to facilitate the TME dissection. On the completion of a successful purse string, the dissection borders are marked out. This is on the border of the radial folds formed by this purse string suture. At this stage, a rectotomy is performed using the guide marked by the surgeon previously. A full thickness rectotomy is performed, ensuring to start in the lower quadrants first. Care is taken to avoid connecting with the abdominal surgeon too early. Once the dissection is complete, the peritoneum is breached in the superior aspect. The surgeons then work together to remove the specimen either transanally or via an abdominal incision. In this case, due to the bulkiness of the tumor, it was removed via an abdominal incision. This procedure allows for a clear excision of the mesorectum. Histology revealed a R0 resection. 44 lymph nodes were harvested, of which none were involved. A Staples anastomosis was performed in this case. This was the last training case for this pilot program. The surgeons involved showed a clear progression through their training, as seen by the graph provided here. The training was completed this year, and further cases are being recruited. Thank you very much.
Yeah, thank you, Dr. Rajesh.
Thank you. This is our training program, the first in the kind in the world, which is outcome-based training program, which they introduced in the United Kingdom. So, which trained about 10 surgeons to start with. So that is what the Association of Coloproctology recommending. We need a proctored, proper training program to overcome the difficulties which the other centers are overcoming. So once we are all well trained, then we might attempt pure transanal TME.
Yeah, that is why, Dr. Rajesh, you are here in this panel.
Thank you so much.
Now I'll read out the questions. Professor, please answer to the questions, please. So I'll read out whatever it is there in the chat box. Please request Professor Leroy for this, for his tap technique sometimes in your future. I don't know what is meant. Lakshmikant from Hyderabad, Leroy is a great inventor. Cannot stop him from coming out with modifications every time we see his technique. Cannot stop him from saying that he encouraged and enjoyed teaching us when we visit him. Sumanoyas, it's simply amazing. Ramji, great effort from you and your team. Thank you, Dr. Leroy, for the very informative and demonstrative lecture. Dr. Arun Goal, wonderful session. Dr. Deepak Subramaniam is there in the audience. Please unmute. Deepak.
Hello, sir. Hi.
Yeah, Deepak, you wanted to ask some question.
Yes, sir. So thank you, sir. Thank you, Professor Leroy. It was a wonderful lecture, and thank you so much for the insights, and thank you to Dr. Baiju for organizing this. My only question is so how the case selection aspect is where I'm getting a little confused here. So if there is a patient with a low rectal growth, and we send the patient for a radiation and try to downstage the tumor, would at that point would Prof in his experience, would he choose to do a low AR or still transanal is what my question is.
You can unmute your mic, Professor.
Sorry. I have to push a button for the sound. You see, it's a complex platform for speaking. It is as for doing a Transanal TME. It's a lot of foot pedal, a lot of bottom, a lot of energy. And but your question is lesion at which level? Low rectum, low third of the rectum?
Deepak, can you unmute?
You are mute.
Yes, sir. Yes, sir.
It's
low
good.
rectum. Low rectum. Yes.
So low third. Low third.
Yes. Yes.
I don't. I've not seen if you have seen the classification of Rullier. That is interesting. So we are speaking between 2 to 3 centimeters above the. So your question is what I propose, because you said low anterior resection. I will not say low anterior resection. As Dr. Rajesh said, I will begin by up to down.
Okay.
Because you said it's after radio chemotherapy, chemoradiation, to evaluate and doing the maximum by up to down. I recommend to do that first to evaluate inside the possibility. If it's a slim patient, perhaps I will do first by Transanal, but I'm recommending for beginners. As we have seen with Dr. Rajesh, doing up to down dissection and combine Transanal, not in the same time or in the same time, but doing and probably doing intersphincteric or low colorectal dissection, but it's not low anterior resection. It is a total mesorectal excision. It's not low anterior resection I will do. It's a colo-anal, sus-anal, eventually, with or with intersphincteric resection, depending of the localization, classification of Rayleigh.
Yeah.
Thank you. Thank you.
Dr. Madhabanda Kaur is thank you the organizers, wonderful session, especially Dr. Baiju. Lati Bhagavan from Gateway Hospital, thank you Professor Leroy and Professor Baiju, great show. Ramji, Subramanieshwar Rao, great show. Dr. Subramanieshwar Rao, are you there? Great show, Baiju. Hats off to your perseverance. Keep it up. It's always a pleasure to hear.
I'm here, Baiju.
Yeah, tell.
No, I truly appreciate you for getting the best in the world on a regular basis. Pleasure. I think if TME establishes itself safety-wise, safety both oncological and technical, I think it will be a good solution for Indian patients across financial constraints. I think I think it's a very good solution, especially when you hand chew. I think it's an amazing procedure.
Yeah. Thank you, Dr. Subramanian Rao. You need to there, stay there, don't go.
Yeah, I'll be here. Thank you so much.
And Dr. Peetambaran, is there any tips and tricks to avoid difficulties in mobilizing the splenic fracture? Professor.
For me?
Is there any tips and tricks to avoid difficulties in mobilizing the splenic fracture?
It's a question for me?
Yeah, yeah.
Okay. Now, mobilization of splenic fracture. Since I'm working in Vietnam, I will say we do lateral mobilization. We don't do a complete mobilization of the splenic flexure for two reasons. First, we have long of the sigmoid. There is no diverticulosis. So this is a possibility to use the sigmoid. We can keep.
Very rarely we'll have to do this, spleen flexion mobilization, right?
It's not systematic.
Yeah.
Even for low colorectal anastomosis.
Yeah. Then Rudra Acharya is an oncosurgeon. He says CRM will be better in TATME. Is it so, Professor? CRM will be better in TATME? CRM.
Circumferential resected margin, you say.
Complete what?
CRM. Circumferential resected margin.
I have not understood.
No, circumferential resection margin will be better in TATME or TME?
As I have shown, the people that believe in TME said it is better. The other that are doing perfectly, you see the difference with the robotic TME. Every time we have a new technology, every time people are saying it's better. But they have a better dissection before, and after they said it's better than better. So I don't understand what means better. What is better is the results of the pathologist. So analysis of the specimen. And what we see, it is exceptional, exceptional. I think since I'm doing laparoscopy, to have a positive margin. I don't remember, or it is very advanced tumor, but having positive margin when we do TME by laparoscopy too. With robotic, same, but with Transanal, we will not do better. It will be perhaps faster, easier for doing the dissection. If we do by down to up, the distal dissection, particularly in male patients, narrow pelvis, with difficulty to dissect from up to down without a robot. But in my opinion, when we read the literature, and you have seen, I have shown, no real difference between and worst. In the learning curve, it is worse than trained laparoscopic surgeon.
Yeah, I think Dr. Prakash is there in the audience. Dr. Prakash, can you unmute your mic? Prakash is on colorectal surgeon from South India, has done more than 1,000 colorectal lab colorectal surgeries. Dr. Prakash? I think he is not there. Okay, anyway. Dr. Li Niu Hui, probably he must be from China. He is giving thanks to Professor Leroy for the excellent lecture. And Dr. Hadil Abhilai, thank you for making this opportunity to watch the nice webinar. I am Dr. Hadil Alalai, General Surgery Specialist, Surgical Oncology Fellow from Baghdad, Iraq.
Oh.
Yeah. Karthikeyan, thank you, Professor, for the excellent lecture. Satvik, excellent session, sir. Any cadaver training program in India? I must ask Dr. Bala regarding cadaveric training.
See, cadaveric training for TATME is not there. See, cadaveric training is available, but probably in future we can ask Professor Leroy to come over here and guide us. As far as I know, there is no TATME model for cadaver.
Yeah, Dr.
In India.
Yeah, Dr. Abdullah, thank you, Professor, for the wonderful lecture. Nguyen Teo must be from Taiwan. Thank you for your lecture. There are a lot of congratulations for conducting this webinar. And Anil Hedur. Anil Hedur is an oncosurgeon from Mumbai. Anil Hedur, can you unmute your mic? Anil?
Yeah.
Yeah.
Yeah. Hi, Dr. Beju, and hello, Dr. Professor Leroy. Excellent lecture. Thank you very much for enlightening us. I think TATME is one of is pushing the frontiers of surgery. What I wanted to know, Professor, was two things. One, the same question about cadaveric training. It is to you and all the panelists here who have experience in cadaver training. We tried doing it once in one of the cadaveric training centers in India, but the cadaver, unfortunately, while putting the port transanally, it's very difficult, and it's very difficult to distend the rectum. Do cadaver training centers abroad also have this problem? And two, do you think the Norwegian fears about TATME will stand?
Will what?
Do you think that the Norwegian fears about the transanal TME are well-founded and they will stand the test of time, or will as the learning curve goes on, we will overcome the problems of TATME? Thank you.
Thanks for your question. The purpose of my lectures was to try to show you that it's not easy procedures, and training program is necessary, but training program in center with high activity of rectal surgery will be easier for beginning transanal surgery. We have seen Dr. Rajesh lectures. I recommend to do as he proposed. And it is what I said in my lectures. Doing, I will say, standard laparoscopic procedure for evaluating the possibility of doing pelvic dissection, doing oncologic approach as he did, mobilizing the colon, exactly the step I have described in my lectures, and finishing, I will say, more and more by transanal. It is easier to propose this for distal tumor. For upper rectum, it's not logic. Even if we can do, I do transanal, pure transanal sigmoidectomy. I have movie showing we can do by transanal. So I do a ligation at the colorectal junction, and I do resection from down to up and pull the rectum, the colon by transanal, removing the sigmoid by transanal, and doing the anastomosis side to hand easier. So
you will use a long scope, is it? Long in a platform. Talking about the S portal.
Yes, I use S portal. Yes. Long. It's better to have long. Yes, to have 20 to push to be inside the abdominal cavity. Yes.
Yeah.
But you do the training as proposed by Dr. Rajesh, and more you will be more comfortable doing transanal approach, transanal dissection, finding the plane, doing distal approach of the dissection around the rectum. After you will have this approach, at the beginning, you will combine with up to down dissection, as we have seen. But you see, I always believe since a long time that it's better to do colo-anal anastomosis after doing transanal dissection than doing a low anterior resection with stapling, multi-fire stapling, crossing stapling of the distal rectum, not well vascularized. And I think it's better and often easier, because when there is a failure of the anastomosis, at the beginning I had failure, I did colo-anal anastomosis by transanal approach. And it is better results concerning functional, concerning leak, the risk of leak. And it is why when people are saying, oh, when we do transanal approach, TME, we have better functional results, we have better lower risk of leak, because they do coloanal anastomosis. They are not doing low colorectal stapling anastomosis with a lot of cartridge and with a lot of crossing stapling line. So I recommend to do this up to down, doing maximum and combine with transanal dissection.
Yeah. I'll read
because when Lassie is speaking of TME, he is beginning by transanal. He's not beginning by laparoscopy, as we have seen with Rajesh.
Yeah.
But I said the standard, the most popular technique, people are doing laparoscopy with transanal approach. But I would say we do that since 30 years. Since 30 years, when I would say my first procedure was laparoscopic with transanal approach, with intersphincteric, with coloanal anastomosis. It was my first laparoscopic procedure because it was a low rectal tumor, and we don't finish the dissection by up to down, but we finish by transanal. So you see, this is not new. What is new is to try to do the same by pure transanal. So it is, I would say, research. It is perhaps future for selected patients. Only to remember one failure I had was obese male patient, super obese male patient. I did all the dissection by transanal. And as you have seen, but after I had to pull the rectum, easy. But I have to pull the colon for doing the anastomosis. But in obese male patient with narrow pelvis, with a fat mesocolon, you have to pull through the anus, and it's not coming. So I did a single port to help me, but so voluminous. Meso, I did multiport. Finally, I did laparotomy to try to introduce the colon in the pelvis. And this is a main problem. This can be contraindication, not for dissecting. This is what I call transanal mesorectal dissection. It's not TME. Yeah, transanal TME, it's complete step of a TME by transanal way. it's a problem of definition. So you have to know how to do transanal approach. You have to know anatomy from up to down. You have seen the different anatomic structures we see by up to down when we do good dissection. We have to know to reproduce the step by down to up. This is my view. This is when people said, "Oh yes, but he's not doing a lot of case." No, because when I do a case, it's not for doing only dissection. It's not doing transanal, mesorectal, or perirectal dissection. I tried to do the procedure for doing TME by transanal. I have demonstrated we can, and I'm not alone. John Marks, I train him. He's following me. He is now doing, and he developed a platform with intuitive for doing with robotic flexible robot of, and he published the case. The first cases he did by pure transanal procedures. He did 4 cases.
Yeah. Dr. Rajesh, do you advocate pure transanal excision and transanal TME, because you have shown a video of hybrid? So what are situations you go for hybrid and what are situations you go for a TME?
This is Professor Leroy was demonstrating, this is a technique, it's advantage, advancing technology, and this is an innovative technology for the pure transanal TME. So when we do for a cancer, when we do a cancer, we do a hybrid technique because we got a male narrow pelvis. We do everything from above as much as we come down, and the lower part alone, we do it through the transanal. But when I do for a benign, for example, proctectomy, if a patient had a ulcerative colitis and he had a subtotal colectomy, I just want to do only proctectomy, I do pure transanal method, and I go through the anal canal and remove the rectum, and I check the inside for any damage or anything. And in that case, benign conditions, you can do pure transanal. Like you don't have to worry about the cancer. So in case of benign conditions like a UC, Crohn's, and those conditions, you can do a pure transanal procedures. And as the technology improves, now there are technology-wise, you got robotic platforms coming up for the transanal, and slowly we can sit there and complete the whole thing with the transanal approach. But it needs training, vigorous training to go into the next level of pure transanal.
Yeah, probably Professor will be disagreeing with you. Professor.
I'm okay. I'm okay. You said I'm inventor. I'm inventor, perhaps. No, this is innovative. This is, I tried to, and I have not seen, I can speak of my training on cadaver, my training on animal model, my training to understand what is the best approach. And you have seen some authors as the Parks have published also what I published before, that the best approach is probably to do the dissection by retroperitoneal approach. I have not time, I've not shown what is my purpose, that is to do a perfect lymphadenectomy along the aorta as gynecologists, urologists, many gynecologists are doing pure retroperitoneal approach for lymphadenectomy. So we have to be trained for doing a pure, fantastic anatomic dissection. You have to invite a fabulous surgeon doing a lecture. That is Uehara. This is a surgeon from Tokyo Oncologic Institute that is doing by transanal through the rectum, lateral lymphadenectomy in 3D. It is fantastic. No blood, all the plexus, all the vessels are dissected, are removed. It is fantastic. So when you have a good equipment, this is a fantastic video. You have to invite her.
We will get the chance to invite him also. Actually,
I can give you the reference, but I was fascinating, and I'm convinced that we will do pure Transanal when we see that.
We will try to invite him here in this platform.
Yeah, no, it's fantastic, fantastic.
Yeah, Dr. H. Ramesh, I think he is there in the platform. Dr. H. Ramesh. Okay, then I'll read out the other questions. Dr. Hitendra Patel, he is an oncosurgeon from Mumbai. Professor is doing lots of early diseases. What's the opinion about the sentinel node for CA rectum? He is asking about the sentinel node for CA rectum. Hitendra Patel from Mumbai. He is an oncosurgeon. Did you hear, Professor? I think he didn't hear it.
So sentinel node in mesorectum, do you want me to answer?
Yeah, please. Go ahead.
What we have done is when we developed ICG.
I must tell you that the ICG mapping is a fantastic idea for identifying the urethra. Urethra also while doing the TATM. Yeah. Go ahead, please.
Yeah, so the sentinel node mapping like breast cancer, okay. So in the mesorectum, so you get plenty of nodes. So you can't map exactly sentinel node. What we have done is through the ICG, injecting ICG near to the lesion, we map out all the lymph nodes. So it goes to all the lymph nodes, and most likely when we go for a high tie, we remove every lymph nodes. So I don't think like breast cancer, we are going to fish out the sentinel lymph nodes alone and do a frozen section to identify the lymphatic spread. But we can use ICG mapping to map out all the lymph nodes and remove it in an en bloc.
Yeah, that's a good answer. From Tony to everyone, respected professor, how do you decide between side-to-end mechanical or end-to-end mechanical anastomosis? I think professor is not hearing. Rajesh, can you answer?
What is the question, Saiju?
Side-to-end anastomosis versus end-to-end. Probably you choose side-to-end when the sigmoid is redundant, is it not? Or
yes. My preferred method is end-to-end. So because what happened in UK, the length of the bowel is not so good. So we need, when you do a side-to-end, we need more length. We need more length. And so that is one thing which we do an end-to-end anastomosis. In the Transanal TME, its advantage of Transanal TME is the end-to-end double pursuing anastomosis. You don't get a dog ear on the either side. So end-to-end anastomosis is advantageous. But again, the study says that end-to-side anastomosis is better for good vascularity. So sometimes when the diverticular disease, we might choose to do a end-to-side, but my preferred method is end-to-end anastomosis, either by staple or coloanal.
Yeah. If Dr. Madhu Murali is there in the audience, please unmute your mic. Madhu? I think Madhu has left. Dr. Ramesh Rajan. Dr. Ramesh? I think they have left actually. Now I'll read out the rest of the questions. Jagdishar Gaud Gajagavani. Great efforts foundation. Rama Garg will please visit a CF if to YouTube link. Anyway, who that? Dr. Rahul, can you unmute your mic? He has raised his hand actually. I think he has left.
Sir?
Yeah, Rahul, go ahead.
Sir,
Yeah.
I think it's by mistake, sir. I didn't.
No problem. No
Okay,
problem. Dr. Rashmi, can you unmute?
Hello.
Yeah.
So it was wonderful, Dr. Leroy presentation. So, like I had the opportunity to spend about 3 months with him, and every day he was trying to do newer techniques. And this Transanal TME, though it's a very procedure will look very difficult, maybe in the month and years to come, I think it will be a standard technique and a gold standard in management of lower anal and lower rectal cancers.
So you got into France, is it? Strasbourg.
Yes. Irkad.
How long?
3 months.
Huh?
3 months.
Okay, fantastic. Okay, Dr. Shannon Joe from Dublin, Ireland. There. Muhammad Abbas from Sudan. Okay, all are greeting. There are no questions actually. A lot of greeting messages are there. Then it's almost 10 o'clock here. We can conclude our program. Dr. Rajesh and Dr. Bala.
Baiju,
Yeah.
I really enjoyed this program. The first time I'm attending, as last week I had a pancreatic chronic, this is benign pancreatic disease surgery by Senadhipan was fantastic. And it was really a good opportunity to meet various people and meet Professor virtually. And this will be the real way forward in the future, where we can just upload from in my office. I'm on call today. I'm looking at my patients as well as doing this presentation. Thankfully, there was no disturbance in between. And so this will be the way forward to see. And also the video clarity was very good. Video clarity was very good. And it's a good initiative, Baiju. Congratulations for a wonderful platform. And your backdrop and IT support is very good. I should say that IT people have done very well for you. And
I acknowledge him. Actually, he is Vishnu.
Yeah.
He is my technical person for assisting me.
Yeah. In the future also, we can select individual diseases like start with diverticular disease, inflammatory bowel disease, benign anorectal conditions, and we can have such wonderful webinars every week. And hopefully you should continue this, take this as a challenge and go globally, and more people will come and more people will know about things which is happening in India. Congratulations. Baiju.
Thank you, Rajesh, for accepting my invitation and joining. And you will be coming back to Chennai within.
It finishes.
That you will have to wait for long. Dr. Bala, please. He is muted. Anyway, he is not there. Actually, I think Dr. Jignesh is there. Jignesh.
Hello.
Yeah, Bala. Yeah, please.
Can you hear me?
Yeah. Concluding remarks by you.
Excellent program, Baiju. You're doing a wonderful work. I mean, lot of people, all over India, even outside the country, also people are participating. Excellent. And thank you very much, Rajesh. Whatever the questions I wanted to ask, you asked, and then you gave a clarification. And Prof, it's extremely good. It's like, balancing act. You have given everything, the pros and cons about TME, and very good lecture with very good videos. I just want to make one comment. One laparoscopic colorectal surgery has come for malignancy. When Stephen Wexner has published port site metastasis, the entire US has given up the laparoscopic surgery for 10 years. And Prof. Leroy and Antonio Lazy, they have published their results. Then we have the classic trial, and all those trials finally proved to be laparoscopy is safe even for cancer, rectum and colon. I think a day will come, a TME also will be accepted. It's all how you do safely, how you can prevent the local recurrences, how meticulously you can achieve. I think Prof will agree with me.
Professor, your turn.
Yeah, thank you. Thank you. It's a fantastic discussion. Many thanks to Professor Beju. Many thanks to Bala and his comment. It is right. You know that I received, and you said at the beginning, the Pioneer Awards of SAGES. This is American Society of Surgeons. It is exceptional not to be American and having an award in the States. And I received this for a Pioneer Award in colorectal, thanks to John Marks, probably, because he was my pupils. He were in France, and it took a long time, as said Professor Bala, to be accepted. At the beginning, all people were against the development of laparoscopy. The difference now is what? You see, 90% of the paper published in colorectal literature are now for robotic or TME. So everybody is doing without training. And it is the main problem. At the beginning of laparoscopy, few people were doing, and it was necessary to have good equipment. But now it's also necessary, and I have tried to show, to have a good platform. There is a technical platform, there is a training necessary to protect the surgical medical team, protect the patient, and having good results. Without training, we understand that Norwegian group have seen a lot of local complications. As I said, in 2000, when I was in Strasbourg, Professor Watanabe was invited, and Professor Okuda did the lectures speaking of transanal surgery, TATA, the beginning by transanal and finishing by laparoscopy. And he said, in Japan, we have stopped due to the local recurrence risk. We had a high rate of local recurrence because standardization were not done. So I have tried to explain what are the standards. When we do standardization, and it was confirmed by other experts, perfect closure, perfect dissection, not traumatic dissection, good equipment, good insufflation, not high pressure, and so on and so on. So if, and I believe, we wish to have perfect standardized procedure worldwide, it is necessary to respect protocol. And actually, we have also the problem of pandemic. And we understand it's not for surgeon unusual, because we know when we have to operate patient with a virus, with hepatitis, chronic hepatitis, with positive virus for VIH, HIV, I don't in English, but we know that we have to respect the different protocols. And there is a danger for the team. I've read the recent paper, July, of Ronan Cahill. There is a huge danger for you, for your team, for the patient, and for all the team, including anesthetic, in when we do surgery today, particularly when we do surgery with gas insufflation, with a risk of virus contamination. So we have to do a good protocol. We have to determine what is the protocol and to have a training with team having experience with up to down surgical procedure for TME.
Yeah, we have a long way to go, in fact, to standardize this procedure and to practice all over the world as the standardized procedure or the gold standard. Thank you, Professor, for enlightening us with your wisdom. Actually, because of the COVID, we are not able to meet in person, probably by the end of the COVID pandemic.
I'm crying.
Yeah, either in IRCAD or in some other conferences conducted by Dr. Bala. We can meet again. Thank you, Dr. Dr. Rajesh and Dr. Bala for joining us. Thank you all the participants for joining and spending your time here. And we'll be having the next lecture by Dr. H. Ramesh on pancreatic cancer next week, Sunday, 8 p.m. Indian time. Till then, bye. Thank you once again, Professor Leroy, for joining us. It's really a milestone for Senadhipan Education Foundation. Thank you all.
Thank you.
Thank you. Thank you.
Good.
Thanks to you.
Thank you. Thank you.